name is Ancha, and as you see on my first slide, I work at George Mason University in the USA, and I'm in Russia quite often because I work with Atlas. Today I will be talking about biomarkers of health from the point of view of a healthy person, because the main purpose of a healthy person is to keep his or her health and to age slowly. The mechanism of aging do not consist of too many components. These are the main components that also contribute to chronic diseases. Two main factors are insulin resistance and systemic inflammation. There are some other processes like fibrosis and calcification of tissues and tissue and organ degeneration. But between these two components that are in red, there is something in common. What is in common between them? They are systemic. These two processes, fibrosis and calcification and tissue degeneration, are local. They can develop in the body, but they begin somewhere, whereas insulin resistance and inflammation are systemic. As people age and other pathologies occur, these two factors deteriorate. So it's slowly worsening of systemic inflammation and insulin resistance. If we look at pathological consequences of such processes, we can see pictures like this that are very often occur in lectures, but these are two distinct spheres. So people who work with diabetes and people who work with systemic inflammation, these are two distinct fields. And these people say that we have cancer, diabetes, cardiovascular disease, and so basically the results of these two systemic occurrences are the same. So actually these are two sides of the same coin, which is a very important coin, of course. So as we age, both of these factors go down. Moreover, people who begin to age quickly are on a slippery slope, which is very fast sometimes, and we can basically see it with the naked eye in patients and in people who begin to age fast. The best way to prevent this slope is not to approach the slope. When you see the slope and you don't want to go down, when you're going down it, it's very difficult to run up. It's better to move away from it and not to go toward it. A typical risk curve for any normally distributed factor with any biomarkers, it looks like this. So here we see the norm, and most people in the population are here. These are people who have not enough of certain factor, which is good in many cases. And then we have those risk groups going toward a bad condition, insulin resistance or systemic inflammation. They can be described by this normal distribution curve. Now let's remember one very important thing. What is disease? Every disease has its clinical definition. As a result of watching the evolution in the 20th and 21st century, we can say that actually disease is a very vague concept. From 96 to 99, we had a medical revolution. That's a fact. But you shouldn't think that it's about the description of many DNA and gene variations or certain anti-cancer drugs. No. The medical revolution was connected to a different thing. It was connected to a redefinition of disease for many frequently occurring diseases. For example, in 1999, a new definition of diabetes was invented. It's not the newest one, but the one of 1999. Before, the old definition was in glucose levels from 140. Now it's 126. The newest even lower. So when this redefinition happened, almost 2 million people, I'm showing the US statistics because the population statistics for America is the best. So almost 2 million people who were not diabetics, next day they wake up and they are diabetics. It's the same with hypertension. 13 million new cases in one day due to a redefinition of hypertension. So people over 160, now over 140. So all those people are now sick. Hypercholesterolemia, same thing. We thought that this was bad, now we see that this is bad too. And as we know from some previous lectures, perhaps it would be better to lower it even further. 29 million new diagnoses of being overweight and obese, because we changed the definition of body mass index from 27 to 25. We got used to 25, but it used to be 27. And you could be much fatter, being still within the norm. So this revolution led to many people who became sick overnight. And if we look at the data from '99, we see that 75% of the entire US adult population is now labeled as having at least one chronic disease. And now, without any changes in definitions, this figure grew even further. So a healthy person is something strange. It's almost something extinct. This is not a good message, but I'll improve my message later. The bad message here is that now all these people need medication. And unfortunately, in a typical medical paradigm, apart from tablets, anything else is valuable advice about what they have to do. And this valuable advice toward somebody who's going down a slippery slope or moving stairs is something, well, we warned you that it was an escalator going down moving stairs. You are on it too late. Now for the good thing. What good can we do? What good can we extract from these data? First thing, definitions are flexible. You do not have to treat them as something rigid. They are flexible. Health and disease are not quantum states. They are a continuum. And we choose where to draw the line of intervention. It's not a very well-defined clinical line. If we change it before, we can change it in the future. And we can treat the continuum by helping people move away from this descending staircase. And it's very good if we can do that by non-pharmacological means, mostly nutrition and components of nutrition. Let's have a look at glucose. This is the old definition, this is the new old definition, and this is the definition of a pre-diabetic state, which was introduced very recently. So the level of glucose in blood over 100 is a pre-diabetic state. Perhaps it's not required to treat it pharmacologically, but it needs to be metabolically corrected. What about these people? We can move that, right? We move that. What about these people? Are they moving toward prediabetes? About half the population who are not moving toward that. If we move them here, maybe they will move here, and we have to treat these pharmacologically. What if they move a little bit further from the curve? Everybody will win. The same situation is with high sensitivity of C-reactive protein in clinical practice. And in this case, we are not looking at CRP as a predictor in myocardial infarction or any serious disease. We're just looking at this factor as a risk factor. And this is something, these are modern recommendations. This is low level, which is great. This is average level and high level. What about the population? Well, again, I didn't find an American or Russian picture. This is Brazil. But again, this is normal respiration, and we expect in other populations is very similar. So in this picture, we see that when this factor is measured for children and adults, we see that adults are more moved toward higher levels of C-reactive protein. You see how much? Right here, we see this border of high risk, and we see lots and lots of adults in high risk zone, and children as well. The percentage is quite high. 10, 15, 20, 25% of children are in the high risk zone for highly sensitive CRP. And this is the 2015 update about interventions which can be recommended for children or adults with high levels of CRP, more than 2.5 or 3. So lifestyle modifications, diet, exercise, hypertension control, certain drugs like aspirin, statins, and so on. And we see a heap of various ultraceutics that strive to abate systemic inflammation. So that's curcumin, carnitine, probiotics, isoflavones, omega-3 fatty acids. And we see that this list is the same as the list recommended for systemic inflammation and with insulin resistance. So these are definitely good stuff that help with various age-related conditions. If we look at these two components of age-related pathologies, we will see that insulin resistance and inflammation are inside one and the same cycle, which is support each other. Quite possibly, we have here a window of opportunity where we can influence these two processes using just one component or a number of nutraceutical components, and move people away from the stairs that move down that will lead to their health deterioration. So the main message is not to get well, to improve their health. It's to stay healthy before the moment when they will need actual pharmacological treatment. This is the curve that describes the typical development of age-related pathologies. So things are okay initially, certain metabolic stresses, and then we see, usually after a catastrophic event, for example, eating 10 cakes within 1 week, we see actual insulin resistance, type 2 diabetes. We need the treatment of metabolic syndrome and diabetes, starting with metformin and so on. And here we have an excellent opportunity to hold off this occurrence. And it's very important to understand that in principle, food consists of matter, of materials. These materials can be consumed separately or with food, and usually their bioavailability is higher in food than in pills. An example which I use, I'm not trying to draw your attention to certain components which I love more than others. There are lots of them that I love. I'll give you two examples. This is omega-3 and omega-3 fatty acids. which we know quite well, and we heard a lot of about that. There are various fatty acids, but here omega-6 are very, very bad guys, inflammatory, and the good guys are omega-3. They prevent inflammation. They prevent the action of pro-inflammatory omega-6. And in our regular diet, we have a lot of omega-6, but in typical Western diet, the situation is that we have a lot of omega-6, and the omega-3 cannot balance out the situation. This is a great picture, which I like very much, because it reflects something that's not a diary of nutrition or any data taken from people who what they think about their diets. But this is the omega-3 and omega-6 in body tissues, biomarkers in tissues, not even in blood. So when we measure that, which really reflects what people have been eating, we see a typical correlation depending on ethnic group, or the ratio of omega-3 omega-6 is different, and cardiovascular death correlation is, you see, it's linear. So this is proof. Why is this message so unclear? It seems to indicate quite clearly that you have to eat more of omega-3 and less of omega-6. It's because the main evidence for this, for these interesting theories, came from epidemiological proof, and they remain within a general advice. But actually, genetically tests that we have, they make it possible to transcend this reality of a general advice. How?
There is a gene, LOX5, that is coding ferment, which is capable to rework both omega-3 and omega-6. But from omega-3, it's inflammatory mediators, and it goes into resolvins, anti-inflammatory. And then people with alleles of LOX5 are very sensitive to Western diet with omega-6. So they are oversensitive, which means that these individuals, when they take Western diet with omega-6 big content, they are more sensitive to imbalance, and they are prone to pathologies, and not necessarily in old age, sometimes in children, and it's all due to C-reactive proteins, which means that omega-3, extra supply of omega-3 can decrease severity of asthma. Look at those genotypes. There are 4 of them, which are here it's 3, 4, 5, 6. There are 1 and 2, but they're very rare. And if we look at those alleles, if we find them, those people are most sensitive to the presence of omega-3 in excessive quantities, and then you need to balance it with omega-3. The other thing that I like to talk about is curcumin. We know that it's good for us, but the problem is that this curcumin that comes to it in the bottles doesn't have big accessibility. When we have it with Indian food, we first take it hot, then we have it with a lot of fat, and in this case, bioaccessibility is much more. We, of course, can't expect Western people to take diet with big quantity of curcumin, so we need somehow to supplement it. It's not necessarily curcumin, but this particular thing has very good evidence of its usefulness. we have scientific data that curcumin is really, really useful for our body. For example, there were experiments on mice when some mice got a high-fat diet, and sometimes they had high-fat diet with curcumin, or they had just high-fat diet. By the way, for the mice, high-fat diet for the mice is exactly like Western diet to the people. It's not just fat; it's also a lot of sugar, because mice are not supposed to eat fat. It's if we give them fat, it's exactly the same thing as if we give people fat and sugar, because people are better. They better take fat than mice. And in this case, it very often happens in people that they have on high fat and sugar diet, they have hepatitis. But in Russia, we do not pay enough attention to this, because it's something that happens gradually, and sometimes it progresses without symptoms. That's how it looks like, how this liver looks like. It's liver steatosis. When we supply curcumin to the mice who had high-fat diet, gave the same result. If they ate as much as they wanted, they didn't have this liver steatosis. And for the mice, it's a revolutionary invention. And if we could do the same for the people, curcumin could become really a great pharmaceutical component. I'm not actually advertising for curcumin, but I just want you to understand that there are certain nutrition components that can be as useful as pharmaceutical drugs. They actually belong to the same therapeutic reality. There is not much difference between them. They shouldn't be evaluated differently. It's the same test on mice that could have been done with some drug, pharmacological drug. Curcumin that we take in food, it looks, if we extract it and put it into the bottle, it will look exactly like a drug. That's what we think about improvement of the health. There are here in blue, we have target population for foods industries, and also we have target population for pharma industries. And you see, these markets, those possibilities are much higher. We normally speak about huge markets for pharmacological drugs, but the most important things happen with healthy people. There are many choices that we make, and there are many components of food that can come into our body with food or not, and they belong to very different chemical types of components, and we can find a lot of surprises if we look at those groups. I'm not going to give you surprises, there are other people who talk about it, but now when I told you about different ways of influencing our health, I want to take one step further into the future and see how we can realistically implement this knowledge, so that not very advanced people who already read a lot about it and only have some additional impulse to go in the right direction, but so that it would touch upon every person in the world, including those who are not sitting in this room. Of course, in the future, we should go for longitudinal monitoring of health. And we have now no doubts that the plans to maintain health should be personalized and based upon his genotype and phenotype, and also on his experience, on his habits, everything that influenced his body. And we should rely upon this research. The second part of this vision is that the spectrum of different treatments that we can use and acceptable means. It should be broadened from pharmacology to non-pharmacological means. Probably the most prospective directions, it's decrease the level of systemic inflammation and insulin resistance in general population. When we look at both these parts, we can see that these things go much deeper than just good advice. It's already not just an advice, it's very concrete, very specific recommendation for what we should do with our health. We also have certain limitations because our doctors are very overloaded. They work with people mostly with diseases. And if we speak about the fact that every person should look after himself, but if we need to do it with specialists, if healthy people will go to the physicians won't cope. Then probably we should have a lot more of doctors or at least medical officers. Probably we should, if everyone needs his own doctor, then we'll need to have more specialists. Probably we won't be able to have so many physicians. This is statistics, how many practical doctors we have. Greece has a lot more of physicians for 1,000 of population. In USA it's 2,000 and average in Europe is close to it. If Russia will be the same probably, and that's statistics. How often people go to the doctor? The majority of people go to the doctor once a year, probably twice a year, and it's the same for the statistics is the same for the last 15 years. And when I am talking about doctors, I'm talking about any doctors, because some people go only to general practitioner. Yes, there are people who go to specialists, specialized doctors, but we are talking about here we're talking about all people coming to all doctors. Sometimes when a general practitioner sends us to some specialists, then we'll go for 5 visits, for example. But if we count how many people can be talked to by a physician, we'll realize that all existing doctors are overloaded. And if we are going to give them this duty to compile specialized, individualized nutrition for each person, they won't be able to cope with it. It can't be broadened to every person. So I have this suggestion to think about new medical profession. Here I called it certified health monitor. A person who would have a diploma, medical diploma, but he wouldn't be a real doctor, but he would be able to watch, to do longitudinal monitoring on the health. There could be health integrator. There should be several offices, not doctors' offices, but probably part of the work will be done through the internet, because such people could collect data from different devices for individual monitoring of human health, which are very popular now. And in the case if there is some negative change in the state of health, probably there was some strong stress or infection disease or something else happened, then this integrator, this monitor, could direct this person to the doctor when it's necessary. But otherwise, these points also would give a lot of information, integration data on the patients. Now, when the patient comes to the doctor, he has to go through all the tests again and again. And we try to balance this by electronic medical cards, etc., but it hasn't happened, even this. if we could take some load over from the shoulders of the doctors and give part of this load to the certified health monitors, which would direct a patient with already existing package of the data, it would be very useful. There would be additional benefits because then we would have a lot of new workplaces, new sector of the economy. Then also we would give a lot to science because we'll understand much better what is it health. We know a lot about disease, but we don't know much about health. We don't know what is our individual norm of reaction. We don't know about every individual person, what is pathological state, what is the border between health and disease. And every person would have this lifetime health support, which would be done by the same person in the framework of this integration scheme. And my last picture, very important one, when we do any genetic, cross-section, we do this test just once because genes is something we were born with. We can't influence the genetic variants that we have. Then next thing is epigenetics. We can change epigenetics, but we cannot do it consciously. Our environment form for us this cross-section, this epigenetic landscape. But after epigenetics, we have diet. Diet is something we can influence. It's something that is closer to genes and to epigenetics, but it's something that we can influence. It's also influenced by our culture and habits, but it's an instrument that is in our hands, and we need to use this instrument because this instrument allows us to undermine this genetic determinism that we often discuss, and sometimes it can be more flexible than it seems. Thank you very much for your attention.
Анча, давайте я помогу с вопросами.
Thank you very much for that wonderful talk. But I have a problem with the idea that we can only go one of two ways, which is do things naturally or do things medically. And doing things naturally with things like curcumin and natural substances, omega-3 fatty acids is good, but using drugs is bad, and using conventional medications is not so good. And I think that conventional doctors, you are correct. They wait until there's a problem and then they try to fix it. But there is now a group of physicians, like the physicians at Atlas, like what we try to do in my clinic in the United States at Grossman Wellness Center, where we're trying to optimize health. So if we look at the parameters that you presented, for example, cholesterol. When I started in medicine, if you had cholesterol of 320, it was okay. Then they moved it to 280, then they moved it to 240, now they moved it to 200. But I presented evidence yesterday that is better if it's 150. It's almost impossible to achieve level of 150 with just diet. But if you use a little bit of statin, for example, maybe just 5 milligrams of atorvastatin or 5 or 10 milligrams of simvastatin, it is possible to get to 150. And similarly, I think you can use low doses of metformin and get the advantages without the disadvantages. You can use low doses of aspirin and get the advantages. So I think by combining low doses of good medications along with a very healthy lifestyle, it will be possible to get not just good health, but optimal health. And I think that that's what good doctors should be trying to do for their patients.
I think it's excellent comment, and this is an excellent question. Thank you so much for that. I do not, I'm not saying that the pharmacological means are bad. I'm just saying that to administer them to entire population, this is a challenge. And one of the challenges is that we do not have enough advanced physicians like you and like Atlas to make possible this kind of combinational personalized therapy available to everybody. But thankfully, food interventions are available for everybody. And this is the first step how we can actually start improving general health in population, in people who do not have direct access to advanced physicians, but have to go just to the regular doctor who will see them once a year. But that's an excellent question. Thank you so much.
Спасибо большое. Да. Милка, пожалуйста.
Yes, thank you. Wonderful presentation. You should consider a career of a motivational speaker. There are 2 points that I would like to make. I really liked your idea of a certified health monitor. I think we need more specialists like that. But there is a point that I'd like to make, and that is that most of the medical doctors, at least in Europe, have no nutrition education. Most of medical doctors have very, well, I will dare to say, shallow genetics education. We need way better education in medical practice as we're speaking at this very moment. And the notion of advanced physicians is interesting. Yeah, we need more advanced physicians before we get to the point of having more health monitors. Is that how you call them?
Yeah, we can think about making better name for this profession, but I think that there is a need to give doctors additional help with that. If we're gonna load them with the health of everybody, not only health of sick people, we really need to provide more for this direction.
Yes,
than
absolutely.
just to say you should also do that.
I don't know what is the situation in Russia in terms of the availability of dietitians and nutritionists. I know that in some countries in Europe, for people, it's difficult to reach those specialists. So we really have to think of how to improve health of the public with the means that we have at the moment. And education of medical doctors would be one of the ways to start with.
Of course, in Russia there is a problem, and this is a very deep problem, because of course specialists are available for those who seek them, but many people do not seek particular specialists in diet because they believe that they will get general advice, and if they already know general advice, eat less, exercise more, and it's not really acceptable for a lot of people, so why would they seek this special advice? And that provides vicious circles that we do not have enough specialists because it's not enough of demand for those kinds of specialists. We should work jointly on this. Actually, I prepared the proposal for a SOF conference on this new profession, and I would be really interested in discussing it with you about the European perspective on this. I know American perspective a little bit better than European, and I would be very happy to discuss this.
Inside nutritiology, can we use the information about who we are, where we are from? Yes, of course, there are certain peculiarities of nutrition which Russia is multi-ethnic state and ethnicity can influence it. But when we look for certain genotypes, it's overlap this necessity of ethnic component inside the same individual, because if we do not of course, if we do not have an opportunity to have the text, then ethnic information is relevant. But if we can take the genetic test, then it doesn't matter because we can get all the information from the genetic test. Thank you. And I have a question. We have quite a lot of evidence, the database, relating to certain drugs. And how much of the evidence of database is there for nutriology? Because we are now mostly based on evidence medicine. And what is the perspective of clinical trials on nutrition? There is a database and evidence, but it's different from the database you work with, because organizing of clinical trial inside of nutrition is more expensive, because we need to because we work with healthy people, and we can't actually we can't go for such grants, such amounts of money, because mostly the components of food can't be protected by patent law. And it complicates things. But as the research in this field are numerous, we can talk about already accumulated evidence database, which was accumulated also by the result. The design of such research is different, also epidemiologic, and if the experiments were carried out correctly, they also can help us to make some conclusions. I want to come back to my research. Just remember this slide where there was this line showing correlation between cardiovascular disease and omega-6 and omega-3 balance in the body. It's the research that was based on concrete marker of distribution of certain component, and if you see something that has been measured instrumentally, it's not questionnaire, it's measurement, then you can see that value of this evidence is much, much higher. And if we talk about main components of nutrition, we have quite a lot of data, accumulated data, that was instrumentally measured. And if you want to more serious evidence, start with those. Thank you very much for your presentation.